Hello, I'm Cate Heil. I am a primary care psychiatry fellow at Full Circle Health. I did my family medicine residency at Full Circle in Nampa, and then I did an addiction medicine fellowship through Full Circle Health in Boise. So thanks everybody for coming today. I know that I have a really soft voice, so if you can't hear me, just say something or send me a chat. Today I will be talking about premenstrual dysphoric disorder, or PMDD, as part of our series on women's or maternal mental health. All right, so to start out with, I have no disclosures. Learning objectives today would be learning how to diagnose PMDD based on the DSM-5 diagnostic criteria, and then listing talking about different treatment options for PMDD, and then understanding the barriers to diagnosis and treatment for PMDD. All right, so to start out with, premenstrual dysphoric disorder, or PMDD, refers to both physical and psychological symptoms that affect women's lives. And these symptoms are definitely exacerbated kind of in this luteal phase down here, which is the phase between ovulation and menses. So this is a chart kind of going over the physiologic like hormonal changes and like ovulation changes that will happen during the menstrual cycle. So going over this briefly, day one is the first day of the menstrual cycle, which is when the menses start. So that's when the uterine lining sheds, also called menstrual flow or period. And then over time, based on different hormones, specifically like estrogen, the menstrual lining will, the endometrial or uterine lining will build up over the next like 14 days or so. And this is all based off of a very like typical 28-day cycle. We understand that there's some variation, but in general, ovulation in that perfect 28-day cycle will happen about day 14. And there's different hormones that kind of cause that to happen, like a spike in LH or luteinizing hormone. And then estrogen will go down while progesterone goes up during this luteal phase. And then the menstrual flow again starts on day one. So again, the luteal phase is the phase of the menstrual cycle between ovulation and the start of the menstrual flow. And again, estrogen rises during the first part of the menstrual cycle and then goes down after ovulation, and then goes back up a little bit again during the luteal phase, and progesterone also goes up during that phase. So we think that there are some hormonal components to the symptoms of PMDD, but we don't think that that explains it like totally fully. And I'll go over that a little bit more in a few minutes here. All right, so when we decided our topics for 2024, back in summer of 2023, we decided to talk about premenstrual dysphoric disorder, not knowing that ACOG, which is the American College of Obstetrics and Gynecology, was actually going to release a new clinical practice guideline. And they just did that back in December. So it's a very, very timely topic here. And ACOG stresses that PMDD is a diagnosis of exclusion. So other medical conditions must be investigated and ruled out prior to making this diagnosis, just to make sure we're not missing anything there. And then included in this new clinical practice guideline was also some guidelines regarding PMS. And I recognize that this talk is mostly going to be focusing on PMDD, but I'll talk a little bit about PMS as well. Okay. So PMDD, or premenstrual dysphoric disorder, and PMS, or premenstrual syndrome, are kind of under the umbrella diagnosis called premenstrual disorders. And if you look at different kind of like resources or different studies, you'll find some variation kind of in the prevalence of these conditions. But in general, we think that premenstrual disorders will affect up to about 12% of women or people who menstruate. And again, the premenstrual disorders is the umbrella diagnosis that includes premenstrual syndrome, PMS, and then PMDD, or premenstrual dysphoric disorder. It is notable that at least 80% of women report one or more physical or psychiatric symptoms during the luteal phase of the menstrual cycle. But that difference where it becomes, something that just we as women can kind of report versus that something that we view as something as like a diagnosis that we can potentially treat or target a little bit better would be the impairment in the daily activities of daily living for these folks. So in general, we think that the prevalence of PMDD is somewhere between 1.3 to 5.3%. And then another study that I found said between 3 to 8%, and this would be in US people. So in general, symptoms for premenstrual disorders can start at any time between menarche and menopause. So menarche is the start of the menstrual cycles, so in early adolescence, and then menopause later on in life. So these symptoms don't have to start like right when people start menstruating. It can happen at any time during their life. We do know that premenstrual disorders are associated with some other kind of negative effects. So there's a higher rate of work absences, relationship stress, medical expenses, and then in general, a lower health related quality of life. Thankfully, though, the recognition of this diagnosis is growing. For example, recently, or as recently as I think 2019, the ICD added this into their diagnostic codes. So we can put it into the computer now. All right. So in general, I'm kind of going back more over the background of premenstrual disorders. The etiology or the exact causes of premenstrual disorders is not very well understood. We think that from several studies, it seems like there is something to do definitely with the kind of cyclical changes in progesterone and estrogen. And we think that primarily, or not primarily, but in part because folks who have gone through menopause that previously had a PMS diagnosis had no symptoms, and then if they started cyclical like progesterone therapy after menopause, they had a recurrence in some of their symptoms. And then we do know that the progesterone will rise during the luteal phase, which is after ovulation and between start of menses, sorry. And we do know that progesterone, like when we do give it as a medication for folks, there can be some kind of mood changes, or depressed mood is a potential side effect there. So in addition to hormones, we do think that there's some other things, like specifically with the mood changes that are affected by different neurotransmitters like serotonin, GABA, and dopamine, which is why we use medications that will target some of those symptoms, target those neurotransmitters. We also think that, the serotonin, GABA, and dopamine systems also affect the renin, angiotensin, and aldosterone system, which could lead to bloating, or which can lead to bloating and swelling as some of the potential symptoms during this time period. Very interesting, because we usually in medicine think of renin, angiotensin, aldosterone as the renin, angiotensin, aldosterone system as affecting blood pressure, but it can affect definitely more than that. And one thing that I found interesting when I was looking at resources for this talk is that this current studies show that people with premenstrual disorders do not necessarily have a higher level of estrogen and progesterone than the general population. And then we do think that there is a possible genetic component as well. All right, so PMDD versus PMS. PMDD, some definition would be, symptoms are severe enough to interfere with the ability to function, comparable with other mental disorders such as a major depressive episode or generalized anxiety disorder. Some similarities between the two is that symptoms are only occurring during the luteal phase, and then after menses, the symptoms resolve or get better, and then they start back again during the luteal phase of the menstrual cycle. Both PMS and PMDD have psychiatric and somatic symptoms that can develop during the luteal phase, affect daily function, and then again resolve shortly after menstruation. So one thing to think about if you're looking up resources or looking at your resources for the diagnosis of PMDD, the American Psychiatric Association, of course, focuses primarily on the psychiatric symptoms written in the DSM-5 diagnostic criteria, whereas ACOG focuses on both. So in general, when we're thinking about diagnosis and treatment of PMDD, there are some different barriers. So a lot of people who menstruate may assume that their symptoms are actually normal or typical, or this is like what always happens or what should always happen during a menstrual cycle. And so because of that, they don't really feel like it's necessary to seek medical care. And one of the studies that I was looking at showed that there was interviewing patients actually showed that it can, in some cases, take up to about 20 years to get an accurate diagnosis. And hopefully now that there's some more recognition of this, that number of years to getting the correct diagnosis will go down. In some studies, it looked like up to a quarter of participants were misdiagnosed before actually getting the correct diagnosis of PMDD. And the misdiagnosis kind of ran the whole gamut, really. So some examples that I found were being diagnosed with bipolar disorder or cluster B or borderline personality disorder, chronic fatigue, fibromyalgia, PTSD, and schizophrenia even. And then among folks who eventually get diagnosed with PMDD, they noted some feelings of being dismissed or invalidated by their medical providers or other providers, and then doubts that they had doubts that PMDD was like a real diagnosis. So there's some particular like societal provider and patient barriers. So patient barriers again would be thinking that what they're experiencing is normal, a normal physiologic thing. Provider like lack of knowledge about this diagnosis or thinking that this was a normal thing for folks to go through, and then societal, like not much awareness about the diagnosis, and again, kind of revalidating that this is, or reinforcing that this is something that happens to everybody. Okay, and then looking at kind of different recommendations from AFP, ACOG, they found that one of the most accurate ways to diagnose PMS and PMDD would be prospective questionnaires. And I'll go over that in a few minutes here, or I have a chart about that. And this is because we found that if, providers are asking their patients, the diagnostic criteria, asking them their symptoms, sometimes we found that there can be an overestimation of the cyclical nature of the symptoms, when in reality they're more erratic or actually worsened during the luteal phase. And then again, when we are talking to folks, we need to have a broad differential diagnosis, including both psychiatric and physical or organic disorders, including some major depressive disorder, anxiety disorders, migraines, anemia, endometriosis, and then hypothyroidism. So ruling out those medical things and ruling out other psychiatric disorders, and providing folks with kind of the ability to get like a diary of their symptoms. Okay, so I'm going over the diagnostic criteria for PMS. There's this chart here, includes both psychiatric and somatic symptoms. And again, the symptoms begin after ovulation and resolve shortly after menses starts. So that would be the luteal phase. And then PMDD, a depressive disorder in which individuals have cyclically recurring severe, sometimes disabling mood and emotional symptoms, again, during the luteal phase. So when we talk to our patients and take a history for them, one of the things that we want them to do is do a kind of a diary or log using a chart that's called the DSRP, or the Daily Record of Severity Problems for Diagnosis of Premenstrual Dysphoric Disorder. Really long, so DSRP is easier. We want them to track and rate their symptoms over at least 2 menstrual cycles, so about 2 months, somewhere in there, and then create a daily log of their symptoms. And then what we do is we kind of score it and a cutoff value of 50 or more gives a positive predictive value of 63% and a negative predictive value of 90% for either PMS or PMDD. And then let's say that person does screen positive, then we can go through the DSM criteria with them to give a diagnosis. So this is what the DSRP looks like. So you have the days of the menstrual cycle here, and then the different symptoms. So they both, if you see, are psychiatric and physical there. And then this is the diagnostic criteria for PMDD from the DSM-5. And then, what do we do once we have this diagnosis? We want to think about treatment for folks. So the goal of treatment is to relieve both physical and psychiatric symptoms. We have a couple different medications or medication classes, I should say, that are used most frequently or approved or have stronger evidence for them. So the kind of two different classes that we have are we have hormonal ones and then we have neurotransmitter ones. So we, with the hormonal ones, we want to suppress ovulation, which happens about day 14, and then the luteal phase is after that. And that would be medications like combined oral contraceptives, and then in some cases they're GnRH agonists, which I'll go over in a minute here. And then there are medications that we can use that would affect neurotransmitter concentration. So that would be focusing on medications that affect the serotonin, norepinephrine, and dopamine systems. And the way we can kind of choose between the two is focusing on are the symptoms that are most bothersome to the patient, are they more psychiatric or are they more somatic type symptoms? And then kind of going from there. And then of course thinking about contraindications to either. And then there are, of course, some complementary and alternative options, which I'll go over towards the end here, and they all have different mechanisms of action. Okay. So looking at treatment recommendations, we have some recommendations from ACOG, and then we have some that I found on AFP, or American Academy of Family Physicians. There's a grade A rating of good evidence for using SSRIs as a first-line treatment for severe symptoms of both PMS and PMDD. Also a grade A recommendation for oral contraceptives as effective treatment. There's some evidence as well for using calcium supplementation that may improve PMS symptoms specifically. And I also found that as an ACOG recommendation. And the thought there is estrogen can sometimes affect the calcium levels or lower the calcium levels, and there's, as long as you're sticking to daily recommendations for calcium, there's not as much harm, or not much harm, that could come from calcium supplementation as well. There are recommendations as well for CBT, both for PMS and PMDD symptoms, and then using DSRP for diagnosis. And then specifically from ACOG, there's a conditional recommendation for using gonadotropin receptor hormone agonists with add-back therapy, which would be using estrogen or progesterone for adults with severe refractory premenstrual symptoms. And that's more kind of is not exactly or not totally a last line of treatment, but we want to try other things first generally. And then as far as other recommendations from ACOG, exercise, calcium supplementation, acupuncture, NSAIDs, and then a holistic approach with self-coping strategies. And then in cases of treatment failure, there can be a discussion on bilateral oophorectomy with or without hysterectomy. So that would be removing both of the ovaries and possibly the uterus as well. Okay. So first-line treatment would be SSRIs. We think that these improve both the physical and psychiatric symptoms. So by the interplay with serotonin, and then kind of the complex interplay between serotonin and estrogen. Ones that are most frequently used would be sertraline, paroxetine, fluoxetine, citalopram, and escitalopram. So you may have heard before that you can take these either continuously or only do during the luteal phase, so that about 14-day-ish period between ovulation and menses, or symptom onset during to menses. This is a little bit difficult, and it can lead to some decreased like adherence to therapy. So most often what I have seen anyway is kind of doing it more in a continuous fashion rather than only during the luteal phase. Looking at other psychiatric medications, so NDRIs like bupropion was not found to be effective. Seroquel or quetiapine, sorry, was studied as an adjunctive for SSRIs or SNRIs. Small studies showed some promise in the luteal phase of mood lability, anxiety, and irritability, but more kind of information is needed there. And then as far as SNRIs, venlafaxine is used off-label for those with predominantly psychiatric symptoms. And then other treatments, so oral contraceptives, we find that they also have benefit for physical and psychiatric symptoms. So specifically like bloating, breast pain, headache, weight gain, and extremity swelling. There is also an improvement in DS or DRSP scores with the continuous use of oral contraceptives, but we know that there's also, or in the studies that I was looking at, showed that there's also a higher placebo response in those with PMDD as well, so a little bit hard to interpret. And then Yaz is a combined oral contraceptive that is actually FDA approved for PMDD. And then other medication options, so there's calcium, more specifically for PMS. We don't know exactly how this happens, but there are some cyclic changes in calcium levels. What I found is like a potential hypothesis is that estrogen kind of lowers the calcium potentially, and that's how we think that that works. And again, if someone is low on calcium and they're sticking to the recommendations, or recommended daily levels of calcium, there's a lower risk of causing harm there. And then also some things you might find are also taking like vitamin D for PMS and PMDD, but there's not enough evidence to make a strong conclusion specifically for these diagnoses. And then again, for vitamin B6 with PMS, again, small studies, more data is needed. And then there's GnRH agonists, which are gonadotropin releasing hormone agonists for PMS and PMDD. Examples like this would be like Leuprolide. These have been in use and are effective by eliminating luteal phase symptoms, so they induce anovulation, so the person does not ovulate. But these are generally only used in the short term due to increased risk of decreased bone density or osteoporosis and then cardiovascular complications. Additionally, what normally happens when these are in use, we do add back therapy like with the combined oral contraceptives, but then that can kind of cause some of the symptoms to happen again, so it's kind of tricky there. And then complementary treatments, what I found was some different Chinese herbal supplements and then acupuncture. There is some limited evidence, unfortunately, but with poor studies, so that's an area that needs a little bit more study there. And then there has been shown to be improvement in functioning in those with PMS and PMDD that engage in CBT. And those are my references, and that's what I got.
Thank you so much.
Oh, go ahead, Tara.
Yeah, thank you so much. That was so helpful, and I love that that tracker. I always have that feeling with patients where I'm like, is it cyclical? I think people, I mean, my experience is that I think I have at least some patients who will jump to PMDD when I really think it probably is more like an underlying depression, anxiety. But I think if we track it, that gives us so much more information. So thank you so much for that. I guess my question about the cyclical SSRIs, that's been like an ongoing question for me because, and I totally hear what you're saying about compliance. People love that idea though, that they don't have to take a medicine every day. And so, and I just, you know, my teaching has always been that SSRIs take 4 to 6 weeks to take effect. And so I just was curious if you came across anything or know much more about like how much of that do we think is placebo when that's useful for people? I didn't know if you had more thoughts on the cyclical SSRIs because people really do like the idea of it.
Yeah, that's a good point. What I found was more specifically for venlafaxine, which is an SNRI, where it can take like 3 to 4 weeks to get to kind of the good treatment effect, specifically for that one. But that would again be with continuous treatment rather than cyclical. And I think
Got it.
my understanding was most of the information that we're getting is from the continuous treatment rather than cyclical.
Got it. Okay, like it hasn't been studied as rigorously, even in PMDD, like the trials aren't as okay.
Yeah, that's
Perfect.
kind
So
of what I
you
found
kind of
anyway.
encourage people to do the daily, even though that's been described.
Yeah,
That makes
I
sense.
think, yeah, I think with my patients, it would be, yeah, a conversation there. I agree with you. A lot of patients do find it nice to not have to take a medication every day. But again,
Yeah,
sometimes we can forget and, the kind of that factor there.
totally. Thank you.
Mhm.
Kate, I had a quick question, and thank you. Yeah, thank you. That was excellent. I had a question on it's the DRSP, right? That's what it is. I hope that's right. Okay. That's a really, really great tracker as well. Thank you for bringing that to the table. I guess my questions are, number one, is that something that we would be able to find just publicly doing a search, things like that, or that we can kind of direct our patients to? And then with that being said, is that something that you know of that, like as a psychologist, right, as someone who works a lot in women's health and perinatal mental health and things like that, I am having people track that kind of stuff all of the time, but mostly people will track it on their apps and things like that they've either got going already or that are really easy to use and on their phones. If I were to give someone like the DRSP, is it supported where like someone like a therapist or a counselor would be able to start them kind of tracking that, and then they can take that information into their provider, knowing that especially in our area, it can take a couple of months sometimes to get into your provider. So yeah, what is the support that you've seen with that type of implementation?
Yeah, good question. So originally I found that on the AAFP website, but I was also able to find it, and I'm going to take myself through it through IAPMD, which is the International Association for Premenstrual Disorders. If you go to their website, and then go to For Professionals and provider resources, the second thing that they have is the daily record of severity problems, or the DRSP, and then you can download it. So personally, yes, thank you for linking that. I think that would be reasonable to have folks, if there is a suspicion for that, to have folks, if they're seeing you as a psychologist, to get that started, because with the knowledge that, like you said, you do need at least 2 cycles to track to fully have that be like validated and get the correct diagnosis there. And additionally, this condition is something that can be diagnosed in primary care. So it can be diagnosed in primary care or in the mental health field. So I think that's reasonable to have them do that and then follow up with either their PCP or a mental health professional.
Thanks, Kate. Thanks, Rachel and Tara. Malcolm, did you have a question?
Yes, I had a quick question. With respect to the starting doses to treat for the SSRIs, should we start them at a dose similar to major depressive disorder, or did you have any thoughts on that, on starting doses for your SSRIs?
Sorry. I realized I was on mute. Yes, so very similar kind of diagnostic, or sorry, treatment recommendations and guidelines there too. So fluoxetine, starting doses like for this would be about 20 milligrams per day. Sertraline anywhere from like 50 to 150, Paxil 20 milligrams, citalopram 20. And then escitalopram 10 to 20. So very similar to diagnosis, or sorry, treatment recommendations for major depressive disorder and anxiety.
Thanks, Kate. Any other questions or comments from our audience or our panelists?
I'll just throw one more thing in there too, and I think this is just a little plug for the tracking piece too, is what I have found clinically speaking is that, you know, yes, CBT is really helpful for that type of stuff. I mean, definitely seeing improvements with that. You know, I'm obviously, as a non-prescriber, less on the medication side, so can't really speak to that piece. But I will tell you, one of the most powerful tools for the folks that I work with that are struggling with this type of stuff is just the knowledge that this is what's going on. It is amazing what happens, and as menstruating people, we go through this every 28-ish days for like decades and decades and decades, yet every single month it's like, oh yeah, that thing is coming, or oh yeah, that tracks. But it feels like it's only been a week or 2 weeks, and come to find out it's been 4. I mean, we just have this way of forgetting and getting lost in our very busy lives. And then it dawns us on so many people when they start bleeding. They're like, oh, that's why the last couple of days I felt really out of control. And rinse and repeat, rinse and repeat, rinse and repeat for decades. So that what I have found is honestly, like the most powerful tool is just the ability to perhaps predict that that's what's happening, or instead, or when it is happening, and they are having, you know, kind of some of those mood shifts or feeling really tired or really weak and things like that, having that thought go, where am I in my cycle? Is this, you know, what this could be? Because a lot of times it becomes very concerning. I've had a lot of people in my office say, I feel like I'm losing it, like I am, and they're really, really concerned that it is this something that is not as fleeting. And so just the relief of knowing, okay, I know what this is. I'm not losing it. Okay, this will be over in a couple of days, has been so incredibly relieving. And even having people kind of relieve some of the symptoms, or at least the pressure that they're putting on themselves about the symptoms. So just a little note to that the tracking itself can be so therapeutic.
Yeah, I think that's a good point, because what you're, or kind of how I interpret what you're bringing up, is kind of validating the person, you know, giving them a diagnosis, and making sense of kind of what they're feeling, validating them, and then they can make a decision on kind of what further treatment they would like, or if they feel reassured just to know that this is something that they're not crazy or whatever. So I think that's awesome. Yeah, any other questions or anything?
I was just going to say, I went to that IAPMD, the International Association of Premenstrual Disorders. It's an awesome website. I don't know, I had never seen that before. And it looks like there's actually a digital tracker to me, VPMDD. So an app that they have on there that looks free. It's like a different organization, but then like a ton of support for professionals and also for patients. And I'm totally with Rachel. Like, I think especially if people have regular cycles, you can also not plan to do like a crazy thing with your family like 2 days before your period. I mean, even, you know, you don't want to shape your life around it, but maybe, you know, not maybe taking that time and taking care of yourself and prioritizing the self-care if you know it's coming can be really powerful too. So yeah, that website's awesome. Thank you so much. That's excellent.
Thank you. All right, we've got about 1 or 2 minutes, so I'm going to try to go quick here. Jim and Catherine, it looks like you both have questions. So Jim, I'll let you go first.
Hi, thank you. Excellent presentation. Can you explain a little more about the course of this through the developmental cycles? I have adolescents who are beginning their life in the menstrual cycles. And does it wane? Does it change?
That is a good question. From what I found, the study showed that these symptoms can develop at any time between the start of menstrual cycles, so in early adolescence to menopause. I didn't find anything that said that it necessarily will get worse over lifetime. There are certainly some different treatment options that we can do based on the age of the person and the severity of their symptoms and what they've tried before. So as far as treatment would go for adolescents, that would be more SSRIs, SNRIs, and contraceptives rather than the more intense things like surgical options or GnRH agonists.
Thank you.
Thanks. Great question, Jim. And Catherine, I'll give you 1 minute and then we'll move to our case for today.
Yeah, I was just curious about how this interacts with pregnant people, if there's a correlation between postpartum stuff, if that's anything that you have seen in your research.
That is a good question. And I actually did not find anything in my research about that. What I found was mostly kind of the resolution of symptoms after menopause, which of course makes sense. But yeah, I didn't find anything about pregnancy or the association with postpartum depression. That wasn't something that came up, but I'll look into that.
Okay, cool. Thank you.
Great questions today. Cate, thank you so much. Great presentation. We're excited to hear what you learned from Jim and Catherine's questions.